Thank you very much. Thank you very much. Thank you very much for the introduction. Yeah, I tried to make this very clear from the beginning. I'm not a statistician. I'm a physician by training. I've worked in general medicine and cardiology, and I've moved on into public health at some point. So being a data scientist is slightly intimidating, and I'm trying not to embarrass myself by talking about data analysis or such things. So what I thought I'm going to talk about a bit today is more how did this actually become a public health question, personalizing lifestyle interventions? What does it mean for us? How do we think about this? And then I would like to give a few examples from our research at the School of Public Health, which aim towards the development of personalized lifestyle interventions. Not even that I can say that we have already developed all these lifestyle interventions yet. Yeah. So this is kind of the overview of today's talk. So lifestyle and public health, or population health for starters. A bit about promoting lifestyle at the population level. Then talking about ecological momentary assessment and just-in-time adaptive interventions briefly, followed by some practice examples as I've put it here. So public health, right? I mean, public health is concerned with the health of populations, and that usually means that we try to prevent diseases and prolong life. And traditionally, and for many probably still, this is what public health means. Tackling poverty, tackling infectious diseases, and on the left-hand side, you see the textbook example of public health. It's a picture of the Broad Street pump in London, where John Snow, during the time of the cholera epidemic, removed the handle of the pump so that the water, polluted water, could be avoided, and thereby he stopped the cholera epidemic. At least that's how the story is being told. There may be other reasons why it has stopped at some point, but this is how the story is being told at schools of public health. Public health has changed. That's not to say that these issues are not important anymore. Some of them are more important than ever. But what we also have to recognize when we look at the current burden of diseases, we often refer back to the global burden of disease studies, that since 2004, I believe, for the first time, globally, non-communicable diseases have been the leading cause of death around the world. Meaning that heart disease, stroke, chronic obstructive pulmonary disease, and cancers are leading the death statistics, not just in industrialized countries, but also in most developing countries. So since then, lifestyle has become an even more important issue, because research has shown, and this is just a schematic, it's not telling you all the real numbers here, but it's a schematic that's quite old already, but still makes the point. Modifiable lifestyle behaviors are responsible for the large majority of these deaths. So you can see a few examples here: heart disease, stroke, colon cancer, diabetes. Between 70 to 80% of the cases are believed to be due to lifestyle behaviors. And obviously, vice versa, if we could get everybody to engage in healthy lifestyle behaviors, we could potentially avoid these deaths, or at least delay them very substantially. So what are these lifestyle behaviors? These are the ones that WHO and generally public health professionals usually refer to. A healthy diet, engaging in a healthy diet. Avoid tobacco consumption. Avoid excessive consumption of alcohol. Avoid too much sedentary time, too much sitting, what you're doing right now. And engage in sufficient amounts of physical activity. Usually we refer to 150 minutes a week or 2.5 hours. Clearly, this is not always happening the way we want it to happen. And here we have examples from Singapore, from the newspaper, concerned about Singapore developing into a nation of overweight and obese. Happened already in some countries across the world, especially the Western countries, but it begins to happen in the Asian populations as well, and especially diabetes as a major concern. And not by chance has the Minister of Health a few years back here in Singapore declared the war on diabetes. First country to declare war on a disease. So clearly there's a lot of concern about lifestyle behaviors on the one hand and the associated diseases. And in Singapore and other countries, efforts are being made to promote healthy lifestyles. So how does that usually work with the promotion of healthy lifestyles? It's been going on for decades by now that people try to promote healthy lifestyle. Essentially pretty much since the Framingham Heart Study was conducted in the 50s or 60s, and these lifestyle factors actually came up as major contributors towards diseases. And initially it was believed that telling people that you're not engaging in enough activity or that you shouldn't be smoking would stop them from doing so. Clearly, we realized over the years that doesn't really work very well. Just because we know something doesn't mean that we're going to change our behavior. So behavioral research has gone on for decades to understand better how can we motivate and promote healthy lifestyles. So we've tried to, theoretical constructs or theoretical frameworks have been developed to address attitudes, to promote motivation and volition subsequently, and all these steps to promote healthy lifestyle or change behaviors. And obviously, this research has proven to be effective in part and has made quite a bit of progress. But I think each and everyone in this room probably knows about the difficulties of changing lifestyle. And New Year's resolutions are such a thing, right? On the left-hand side, you see a couple of them here in Singapore. We just had Chinese New Year, so I don't know whether some of you had New Year's resolutions. But what we know also is that people who have such resolutions and intend to change behavior, they may achieve that for a short while, but usually they don't manage to maintain it over very long. And from gyms are usually the most obvious place, at least I find it always a very obvious place, where you can see that they are crowded at the beginning of the year, and then after 4 weeks or 2-3 weeks or so, they get empty again and you have your space for yourself again. So that's a common perception. So clearly, changing behaviors and changing lifestyle is a very difficult task. Research has demonstrated that by improving the personal relevance of strategies, of interventions, we can improve the effectiveness of our interventions, of our health behavior interventions. So how can we do that? Targeting has been something. Targeting certain groups of populations. So we target groups that are similar in respective patterns. So for instance, only males or only people of a certain age group. So we make the interventions, the strategies more relevant to them, and thereby we can increase the effectiveness incrementally. So it was found that obviously targeting is good, but can't we do better? Yes, of course we can. Tailoring is something. We can tailor intervention to the individual, so we can try to personalize the intervention. We can try to take into account his or her age, his or her health state, his or her attitude towards behavior, or starting points where they are in the transition to take up a certain behavior, and then we can try to tailor our intervention, personalize them to that individual. And again, studies have found that this is effective. It's more effective than simply providing generic interventions that are targeting everybody. And there's a couple of good examples out there. For instance, the diabetes prevention program, which has demonstrated effectiveness to prevent diabetes by intensive lifestyle modification. The problem with such interventions is often that they are very resource intensive. It takes a lot of time, it takes a lot of contact time, face-to-face contacts with clinicians, with practitioners, to actually get people and personalize the intervention and really make it relevant to them over time. So there remain common challenges in the existing or in the traditional approaches to lifestyle interventions. Important ones are that they tend to be static. They tend to be static and don't adapt over time because we don't see participants so often. We may have an intervention in place. For instance, here in Singapore, we implemented an intervention to promote physical activity in parks. We see them at the beginning of the study, of the recruitment, and we try to tailor the intervention to the individual needs, but then we don't see them anymore for 6 months or so. So there's no adaptation going on in terms of what has been happening. Yes, we can try to improve that by phoning them or calling them, but there's limits to how often we can get in touch with people, obviously. Another problem with such interventions is that they are usually not dynamic, or they don't take dynamic relationships into consideration. Data is collected at one point in time, often through very crude measures, and we don't really know how behavior fluctuates across a day, across a week, and how this fluctuation in behavior relates to fluctuation in other states that may influence the behavior. So we don't have information on these kind of things. Another important problem is that the information that we use to tailor interventions is actually gathered in a very artificial setting. Either people come to visit us in our study office, which is here at MD1, a huge building, there's a study office, very sterile circumstances, and they tell us about their behaviors, which supposedly they engage in all the time, and then we take this opportunity to try to tell them what to do. Clearly, this is not reflecting real life. Or it may be the clinician's office, where many people are nervous, stressed about seeing the physician and so on, and then they get advice on how to change their behavior. In the best case, or in certain cases, we may be able to gather information at home. So we often do that as part of our population-based studies, that we actually have home interviews. At least the stress level is slightly less. But still, it doesn't really reflect the day-to-day situation where they go about their daily lives, when they are answering a 2-hour questionnaire on all kinds of health behaviors, mood status, stress levels, and so on. So there's a lot of problems. There's quite a number of problems with the current or traditional approach to changing lifestyles. And then there's the issue of contextual factors. There's a huge amount of contextual factors that we traditionally do not take into consideration when we tailor our lifestyle intervention, such as where exactly people live, who they interact in throughout the day, when they engage in certain activities, and how they may be prompted or nudged by their environment to engage in certain behaviors or others. And this actually brings us to a very fundamental concept of public health, that in public health is well accepted and is kind of the basis for any public health intervention for decades already, which we refer to as the socio-ecological model of health and health behaviors. Essentially, it means that behaviors are not only dependent on the individual, but they are influenced by multiple levels. We speak of multiple levels of influence, and these multiple levels somehow influence the behavior, but also influence each other, and in practice need to be taken into consideration if we really want to maximize our intervention strategies to promote healthy behaviors. Okay, moving on. Physical activity in mHealth. My kind of pet topic in public health is physical activity-related research, so promoting healthy lifestyle. But it's also a topic that is very relevant to this talk of personalizing interventions, as probably many of you know already, but I'm still trying to make a point why it may be particularly so. Firstly, yes, we all know physical activity is good for health, right? Tons of studies by now have shown that if you engage in higher levels of physical activity, your health tends to improve. Mortality is delayed, diseases are delayed, and there's a very strong dose-response relationship. Obviously, at some point, the effects seem to plateau off, but this is at a level of activity that is multiple times beyond the current recommended levels of physical activity in most recommendations. So in that sense, it's good news because physical activity is definitely good for health, and the message is very simple. That most guidelines put out there nowadays. Some activities is better than none, more is better, and you can't engage in too much physical activity, which as a matter of fact is actually the main concern many people have, especially those who are not very active. They're often very concerned they may engage in too much physical activity and thereby harm themselves. Very unlikely that this is going to happen. So how do we measure physical activity? Traditionally, we have done that with questionnaires, just like for most other health behaviors and actually health states as well. When we think about large population-based studies where we try to recruit tens or hundreds of thousands of participants. Because these questionnaires are fairly quick, simple, and can be administered to large numbers of people in an easy manner. So if we look at the proportion of individuals in Singapore who are sufficiently active, we have quite good data from the Singapore Health Study that we conducted at our school. We can find that about 3/4 of the population are meeting current physical activity recommendations. That's not so bad, but it still leaves quite a fair proportion of individuals that we can do something about. 28% are not currently engaging in sufficient levels of physical activity, much higher than the smoking rate, for instance, in Singapore is. So in that sense, good rationale to try to do something for population health by nudging these people into the active category. There's another reason why physical activity may be particularly interesting for personalized lifestyle intervention. And that relates to how we measure activity. Because I've said we use questionnaires, but actually, when you work with physical activity-related research in public health, you like technology, you like devices. And they have actually been used for a long time already. Pedometers have been introduced decades ago. Accelerometers are available for at least 20 years by now. And all these devices allow us to monitor a person's activity behavior in research settings in quite a bit of detail. We, as researchers in this field, like these devices because we know they are more accurate. They are not perfect, there's all kinds of limitations, I'm happy to discuss them, but we know they are more accurate than simply asking people because they avoid issues around social desirability bias and they avoid issues about recall bias. Physical activity and related behaviors is a complex behavior. It happens all the time, 24 hours a day, and recalling it accurately is very difficult. So we know these devices can do better. Looking at our Singapore population again, let's take some data from the same study that we have collected and see what proportion is physically active. This is what it looks like. So we know they are more accurate, and the picture actually flips around, right? Only about a quarter of the population can still be considered active, according to current recommendations, if we use device-based objective monitoring data. Yes, sure, sorry. The recommendations are to engage in about 150 minutes of physical activity per week, moderate to vigorous intensity. So 2.5 hours per week. They're a bit more refined, but this is the general recommendation. And it's more or less valid across the world. There's another reason why we like them in physical activity research, because they don't just tell us this kind of aggregate level at the end, but they actually provide us very detailed information. This is just a snapshot of my own Fitbit data at some point. You get activity patterns throughout the day, minute by minute, or with our research-grade accelerometers, even at a much finer resolution. So we can derive or look into activity patterns in a much more detailed way than we can do it with traditional questionnaires. This has been the case until very recently, and only a few years ago, wearables became popular and became a wearable. I don't remember when the first Fitbit came on the market, but it's not that long ago. But since then, we had seen a host of new wearables, devices, Fitbits, Jawbones, Polars, and whatever, you name it, and which allow us essentially to do the same thing than what we do in our research studies, to monitor a person's activity behavior objectively over extended periods of time. And they do not only measure activity, increasingly they measure other things. They measure physiological parameters such as heart rate, stress levels, they measure sitting time, they measure other behaviors such as sleep, for instance. They can measure location as well, GPS, via GPS, you name it. There's probably tons of other measures that they can actually generate and that can potentially be used. So clearly they have become very popular, also for many of you, you're here in the room. So that's why, in a nutshell, that's why from a physical activity researcher's perspective, using mHealth has a lot of appeal, at least. So it's very interesting for us because it can help us translate our research setting into a more real-world kind of setting. Developing lifestyle intervention. That's the next part I want to talk about. And if you by now wonder, what is this panda popping up here about? What's that actually? That's a research program that we have at our school that I'm leading together with one of my colleagues with the specific goal to look into the determinants of physical activity and nutrition in Asia. I mean, to be fair, currently mostly in Singapore still, because we only set up the program about 2 years ago, we're able to set it up. But the goal is to obviously look into it more broadly. And the broader objective of this research program is to better understand the determinants of lifestyle behaviors, in particular these two, in order to develop interventions that are more successful and that are more effective in preventing overweight, obesity, and diabetes as some of the key concerns currently here in Singapore. Our program has three main kind of areas of work. The first one is concerned with mapping the environment. So actually nothing to do with personalized interventions. We just try to map the environment in terms of how conducive is it to a healthy lifestyle, such as healthy diet or healthy active lifestyle. The second key part of this program is concerned to understand how do people actually interact with their environment. How do they use their environment? Because we know from association studies for a long time already that certain aspects in the environment are related to health behaviors. But we don't really know how people really interact with these environmental aspects. And finally, and that's where today's topic kind of becomes relevant and where our paths cross, we aim to develop personalized interventions that can help us to promote healthy lifestyles. And particularly work area 2 and 3 are based on the use of mHealth technologies or on technologies more broadly. I have to admit that, yeah, we had already conducted a few smaller pilot studies, intervention studies, I mean, but we actually at this point in time, we don't have any real-time intervention studies in place that I could report results on. But what I'm trying to do, I'm going to give you a few examples later on the kind of work, or some of the work that we have already done to illustrate some of the challenges in particular that we have faced. When we think of mHealth and how it can be useful for us, we are thinking of these broad methods or methodological concepts. The first one is ecological momentary assessment, EMA. And I'm going to talk a bit more, but essentially it's about collecting information on individuals' behaviors and all the diverse influencing factors through sensor technologies and through surveys based on mHealth. And the other aspect is just-in-time adaptive interventions, which I know you have already heard about quite a bit as part of this whole series of talks, where we hope to use mHealth strategies to develop or implement real-life interventions to promote behavior change and overcome some of the problems that I have tried to highlight early on. Ultimately, these two are linked, because what we do in EMA, and when we apply ecological momentary assessment, EMA, is actually also the basis for the implementation and for the development of just-in-time adaptive interventions. So they are very closely linked. So what is EMA and why? For us, EMA is not intended to replace our current approaches of data collection. It's rather, the way we see it is rather an extension of how we currently collect data in our large population-based studies. The advantage is that we can collect information in real life while people go about their daily lives on behaviors and other aspects, and in real time. We're not restricted to one particular point in time only, but we can actually collect information not whenever we want, but we can collect it fairly frequently at least, or we can try to. And we can use multiple assessments, and all this via the use of mHealth, technology. So essentially that means that we may equip a person with a wearable device, or we may use the sensors inbuilt in the phone, which automatically gathers information, collects information on certain parameters that we are interested in. And on top of that, we'll send out surveys to the participants, questionnaires, brief questionnaires, to understand why they engage or why the current situation is actually occurring in terms of behaviors, or also the relationship between behaviors and, for instance, contextual factors. So we try to figure out when do people engage in certain behaviors, where, under what circumstances, with whom, and what has perhaps prompted or influenced them to do so. And with that, we are hoping that we will be able to better understand how people's behaviors shape up in real life. So how their behaviors, what behaviors they engage in, and also how their behaviors change over time. How behaviors relate in real time and on a finer time scale to certain either antecedents of the behavior or consequences of the behavior, such as mood levels, for instance, or stress levels. And also how the context and the various contextual factors, such as the social context, the built environmental context, but also policies, may influence these persons' behavior. In just-in-time adaptive intervention, JITIs, we then hope to be able to use this information to identify under what circumstances are individuals particularly open to behavior change strategies. So are they vulnerable either to unhealthy behaviors, or are there opportunities for healthy behaviors? And we are hoping that we can deliver the right type of intervention for this particular person at the right point in time as well. So for instance, when you're entering a food market or a food court or hawker center, we could hope to, at this point in time, provide you the right information to choose a healthier lifestyle or over an unhealthy lifestyle, or a healthier diet over an unhealthy diet. The idea is also then that rules and also decision points potentially can be adapted over time. So that while at the beginning, people may engage in a certain behavior, and we may have certain rules related to this, But because the behavior changed over time, either as a consequence of our intervention or as due to other reasons, that we can adapt our rules and thereby make the intervention more personally relevant, continuously more personally relevant, and thereby increase its effectiveness. And very importantly, we're also hoping that it will enable us to avoid suggestions or interventions at the wrong that are delivered at the wrong point in time, because this is something that we found in some of our early pilot studies. People don't like at all. They don't want to be prompted about something that they clearly have not engaged in at that point in time. So we found that this is definitely something they're not too happy about. And this is, in JITICE, this is a continuous process where the intervention evolves over time and thereby potentially keeps relevant for the individual over time. So like I said, in PANDA, this is only, in our PANDA program, this is only one part of it. We actually have a number of projects that are concerned with other aspects to the different work streams. And like I said, we are still working on we are now 2 years into our program and we are still working on the intervention side of things. So this has to come in the next workshop series, I'm afraid. But now I would like to take out a few projects to highlight some of the results or some of the challenges that we are facing with collecting the kind of data that we actually need for either better understanding a person's behavior or for the delivery of effective just-in-time adaptive interventions. So the first project is called Parks and Health. It's a project that we conduct in collaboration with the National Parks Board that's being funded by the Ministry of National Development here in Singapore. And this project broadly aims to understand the influence of parks and green spaces on well-being and health. In our case, the project has 3 work packages. The first work package aims to understand the relationship between built environmental features and health and well-being. In particular, how parks and green spaces relate to health and well-being. And we do that by performing geospatial analysis, or gathering the right amount of information first of all, and then performing geospatial analysis to actually develop these environmental variables. The second work package is trying to understand how do people perceive to engage with the environment. For that, we are conducting surveys among participants and trying to understand how frequently do they engage with parks and green spaces, under what circumstances, what are the barriers, what are the facilitators, and who are they doing this with, and a number of other questions. And then the third element is the one most closely related to mHealth, is the one where we perform objective monitoring to understand how participants really engage with their environment, to give us further insights into their behavior and their engagement with environmental characteristics. The project is still ongoing. So I don't have any results yet, but I said initially I'm not going to share any results anyway because I'm too concerned about the data analysis part. So the 3 work packages that we're working on here. We have the geospatial analysis, which we conduct on all of our cohorts, all of our schools cohort participants, or at least most of them, more than 50,000 participants, where we have postal code data and when we can apply this analysis. The survey, work package 2, is conducted on about 3,000 participants, where we try to look into more depth into the interaction with the environment. And the objective monitoring part is conducted in among 500 participants, and I'm going to talk about it in a bit more detail in a second. But I think this in itself, for somebody who is perhaps not all the time involved in data collection or running population-level studies to help to change people's behavior, this is already very indicative of the people we can reach. Geospatial analysis with available data. Once we have the data, very simple. We can do it for anybody we want. We have more participants in our cohorts, we can do it for more participants. There's no limits to what we can do. Questionnaires and surveys to administer, to capture additional information from our participants. Also fairly straightforward. We managed to recruit about 3,000 participants within only 7 months or so. Without much effort, since our school has a fairly well-oiled machinery of conducting population-based studies. Objective monitoring using devices and other aspects, much more challenging, much more resource-intensive, requires a lot more manpower and financial resources, and therefore we can only do it on 500 participants. So the information that we are capturing here, in terms of how generalizable it is, obviously somewhat debatable. How exactly does this objective monitoring in our context, in this study, look like? It has three key elements. The first one is the ecological momentary assessment via a smartphone application. So we have a smartphone application and we are administering regular survey prompts, in particular related to the engagement with parks and green spaces, but also some other aspects, to try to better understand participants' behaviors. The second element is location monitoring. We use GPS tracking, again via the smartphone, to monitor people's movement across Singapore and thereby have information on where they are at what point in time. And finally, we're using the accelerometers I have already been talking about before to have objective data on movement, on actual physical activity levels in fine resolution that will allow us to determine and classify physical activity patterns later on. And all of that we are conducting for 9 consecutive days. So 9 consecutive days, following usual approaches in the area of physical activity monitoring that's usually trying to capture a full week, so that it's kind of reflective of general life. For the ecological momentary assessment surveys, we're using a smartphone application called MovieSense that allows us to schedule fairly complex survey patterns for participants in various ways, according to certain times of the day, in random modes, and following up on each other, depending on other aspects. So quite a complex application that allows us to do a lot of the things that we are interested in. But actually, it was not so easy to find the right software. While there's a lot of stuff out there on the market, it seems, that enables ecological momentary assessment, even free smartphone applications nowadays. We piloted a fair number of them, and most of them were actually not reliable in doing the kind of, administering the kind of surveys that we wanted to perform. And ultimately, to be frank, we ended up with only one that we could use. We may have missed some. We didn't do a comprehensive review of all the software that may have been available at this point in time, but among the ones that we found, only one was actually sufficiently reliable that we felt we can use it. And in fact, even there, we had to accept certain limitations. So for instance, this smartphone application is only available for Android systems. So we're losing about 30% of our population in our cohorts because they have iPhones. We were also not able to use geofencing. We actually wanted to use geofencing, which means that surveys are prompted according to certain locations. And that was obviously very interesting for us here because we wanted to capture engagement with parks. And the idea was to capture this information via geofencing. But unfortunately, MovieSense, but also other softwares that we tried, was not sufficiently reliable to allow us to do that. Still, we get very interesting information from this objective monitoring. We have information on location from the geospatial analysis. We can now identify certain environmental characteristics, and we can then overlay this information with the actual location monitoring to understand where people were at what point in time, what kind of transport, for instance, they've chosen, and other relevant questions. So, in general, there's quite a bit of promising information in there in the data that we are collecting. And by combining it with the accelerometer data, subsequently, that also gives us time-stamped information on activity behavior. We can then also derive how active and to what extent this is physical activity as we would like to see it in our population. I'm going to highlight a few more challenges that we actually encounter across the way, and just by matter of giving you a bit more details about this project, especially the objective monitoring part now. So, for instance, in terms of recruitment, our target sample size is 500, and we have already recruited about 413. That was the status about 2 weeks ago or 3 weeks ago. So we're getting close there, and things are going reasonably well. But what you may also see here is that actually, during the time that we were able to recruit these 400, more than 5,000 participants were actually seen by our cohort team. And more than 3,500 people were approached whether they would be willing to participate in this study. Ultimately, 3,000, about 3,000 at this point in time, either refused or were not eligible to participate in the study, and we ended up with these 413. So there's a huge drop in, or there's a huge selection going on here in the sense of what number of participants we can recruit and also who we may include. And we are doing quite a bit of, we are trying to collect in great detail information on why people are either not eligible or why they refuse to participate. And technological reasons are not rare among them. So for instance, the availability of a smartphone in the first place, the availability of a data plan, the ability to use smartphones and smartphone apps. So all these kind of issues in real life are challenges for us when applying such an ecological momentary assessment studies. What I found very interesting, and I would be happy to hear later on about other people's experience, I was most concerned about the location monitoring because I felt people would be very concerned about personal data and identifying them. We only have about 30 people who refused because of the location monitoring, but we have about 250 or 300 people refusing because we wanted to give them an accelerometer. So in that sense, I was surprised to see that location monitoring doesn't seem to be such a major problem, at least in our study. Even after we recruited these about 413 and we did a rough check, I can't be 100% confident at this point in time, but we did a rough check of what proportion of participants will have complete data at the end. And it's about 75%. So among these 413, about 75% will have complete data on surveys, location, and accelerometer. And by complete, I actually don't mean complete. I mean complete enough to be usable, because there's a lot of missing data actually that we see in the collected information. One important issue that we encounter that we also didn't anticipate beforehand are, that maybe because we were naive at the beginning, was smartphone incompatibility. So beyond the fact that we cannot include iPhone smartphones, a lot of smartphone types are actually incompatible to the software we're using here, but also to other softwares we've been trying to use. Specifically, we had issues with battery saving functions. So many smartphones nowadays use battery saving functions, and they switch off the app if it's not being used continuously, and if the app is switched off, we can't administer surveys anymore. We found a way in some smartphones to reset them, essentially, but they tended to turn off again during the night. So that's quite a bit of an issue. And then we had identified certain smartphone brands that, for whatever reason, don't work at all. Huawei, Oppo. So many of the Asian-made brands or China-made brands, I'm not an engineer, so I don't understand the details. But we have major issues here that we cannot use these kind of smartphones. So in that sense, it's not just iPhone versus Android, but actually within the Android pool, because there's so many different types, it has quite important implications for the implementation of such a study. In terms of the location tracking, here's what this may look like when we see a person moving about and when we track this information via GPS. But as if you, okay, I should have shown you both pictures at the same point in time. Initially, it looked quite nice and smooth, the whole transition. But this is after people on our team have actually tried to smooth the data and clean the data. Because when we look at the data, the raw information, we see a lot of artifacts, a lot of movement artifacts and inconsistencies in the data. And common issues that we are facing relate to drift during journeys. So no consistent information. We see missing data and then spontaneous teleportation to different places because of taking the MRT or so. We are struggling to really differentiate transport types because different types of transport, like taking a bus, cycling, walking, may actually in terms of speed and the pattern not be different enough to really use location data to differentiate them. There may be ways if we integrate the activity data measured via the accelerometer or via the smartphone-based accelerometer to tease that out, but currently we are definitely still struggling with it. We see a lot of inaccuracies in measurement, also in static location monitoring. So that when we have a person's, what we assume is the home address, for instance, we see a lot of fluctuation around this place, and it gets worse because the signal strength seems to be stronger in open areas as compared to houses or so, which means that automatically our signal drifts towards the open areas around them, which are often parks. So we get a lot of artifactual park time people spend in the middle of the night, between 1 or 3 o'clock in the morning, but actually not moving about in the park. If you want to know more about this particular part of the movement data, I highly recommend to visit the talk of my colleague Bo Dickens on Friday, who's actually going to go into more detail on how she and her team is trying to make sense of this data and clean the data so that we can really use it for the purpose that we want to use it for. So that's some examples. That's an example from our Parks and Health project where we try to collect this kind of EMA data. Device accuracy is another issue that we have always been interested in because like I said, from a physical activity researcher's perspective, we have been using devices for a long time. But they have always, in public health, we often try to make sure that devices we use also measure what they are supposed to use. And don't just say that they measure what they are supposed to measure. So in that sense, we got interested in looking into the accuracy of devices. And as I've already mentioned, there's a lot of different devices out there nowadays. They measure tons of different things. We got interest for very specific reasons in heart rate data, because many wearable devices nowadays have the capability to measure heart rate data. So this is a project in collaboration with Health Promotion Board here in Singapore. And actually, I have to give credit that they really try to make an effort to get their data to a higher level and make the information that they're using in their programs are more interesting. So in this project, we try to validate heart rate data from wrist-worn wearable devices in comparison to a gold standard or kind of the best possible reference in real-life settings, this chest strap that you can see here. So in this particular study, we investigated 2 wrist-worn devices. The first one is the one that is being used in the National Steps Challenge here in Singapore. The second one is a fairly expensive consumer device from Polar as a proxy for other potential consumer devices. We had actually looked at others before, but this is just a more recent example. Quite a comprehensive study, I feel, we conducted here. We recruited about 55 participants or so. It had a lab component where we put people on a cycling ergometer and made them cycle and measure their heart rate at the same point in time. And we did a free living study where we asked people to wear the chest strap, the 2 wrist-worn devices, plus some other devices that would allow us to monitor and store the relevant information here that we needed for our study. I'm not going to go into much detail because actually we are just wrapping up this project. Just some early preliminary results. If we, for instance, look at one of the wrist-worn devices in relation to the reference, the Polar H10, what we see that overall, there's a fairly decent correlation and agreement of about 0.5 or so. But you can also see that there's a lot of weird measurement errors going on, and it's very hard for us. Sometimes it seems to be related to devices, to specific devices. Sometimes it seems to be related to specific individuals. But we can't really say that this is the reason for why some devices or some individuals perform so much better than other individuals. We could not find a clear pattern at this point in time. Sorry, say that again?
Why the bias is always full of agents, right? It's not like squid, right? You can see the bias is always towards the x-axis.
Yes, so I mean, the bias is towards measuring lower activity from the wrist-worn device as compared to the reference. And this is what you actually can, people who are into data can pick these kind of things up much more quickly than I can, right? This is what we see when we look at it actually by heart rate heart rate level and intensity of heart rate. We see that at kind of low to moderate intensity, the heart rate seems, the devices the measurement error is a lot smaller. But when you move up to higher heart rates, as reflected here by deciles of heart rate intensity, the measurement errors become a lot bigger and also more variable in a sense. So this is what we have seen, that in the normal heart rate zones, so to say, between 60 or 80 or so, there's pretty high agreement actually. But when you move up to higher heart rate zones, then the problem, then it really becomes a larger difference. And in fact, when we look at the proportion of episodes of moderate or vigorous intensity activity, this is what we are interested in from a physical activity perspective. What time do people spend in moderate to vigorous physical activity? We realized that both devices actually are missing a large proportion of episodes that are actually, according to the Polar H10 at least, performed in these intensity levels, because they can't seem to pick up the higher heart rate intensity very well. Already 2 years ago or so, we published a paper. It was one of the earlier ones on step count validation, where we compared step count data from a Fitbit, one of the first Fitbit Flex, I think it was, compared to a reference device at the time, the Actigraph accelerometer. And we found a very high correlation between both devices, 0.9 or so. But the Fitbit tended to overestimate step counts by about 1,400 steps or so a day, which is more than 10%, which is definitely more than 10%. Since then, there have been quite a number of validation studies on step count data. We recently completed one, actually just last week, so that's why I don't really have a lot of detailed results, but we just completed one last week because what we try to compare is a whole host of different trackers that are being used in the National Steps Challenge in order to enable us to make the data in the National Steps Challenge more comparable subsequently. And these are the mean step counts as derived from these different wearables that we have tested here. I think 8 different devices. One of them is data based on phone step sensing. And on the left-hand side is the reference device, the gold standard pedometer, so to say. And again, interestingly, what we see, when I looked at this data for the first time really a few days ago, I realized that there doesn't seem to be so much overestimation going on anymore. Only one device, I think, is estimating actually higher step counts as compared to the reference, which may be a reaction by the device manufacturers, that they have realized their devices tend to overestimate and they've changed their algorithms. Can't be sure. But what we certainly still see is quite a fair amount of variation here, and mean step count ranging from about 5,000 a day to almost 10,000 a day on the same participants, only using same day data on total step count. So this is really comparing exactly the same people at exactly the same point in time in terms of monitoring device data. I mean, clearly this is not such a novel topic anymore, taking step count, but what obviously makes me wonder about is if step count has been the measure that has been on the market the longest time probably for these kind of wearable devices at the moment. If the companies can't even get them right for this fundamental measure, how trustworthy is the data really for heart rate, stress levels, and other potential information that we may be collecting via wearable devices? So for us, I think an important lesson is, if we want to use wearable device data, we also need to make sure that we first check that it's actually accurate and not just pretending to be accurate. Yeah. Getting to the end of my time and also to the end of my presentation, participant engagement is something that we noticed is obviously something important, right? Especially if you're thinking about just-in-time adaptive interventions. Because for EMA, ecological momentary assessment, the way I've described it, we only need about 7 or 9 days of data or so, which is fine. People are usually fairly open to wearing these devices and monitoring over 7 days or so, or 9 days even, without major problems. But if the fundamental idea of just-in-time adaptive intervention is meant to come true, that we monitor individuals continuously, and we monitor them not just for a week or for 2 weeks, but we actually monitor them for 6 weeks or 8 weeks or 2 months or 6 months or even a year, because we want to adapt our interventions according to the changes in lifestyle. People need to be willing to engage with these kind of technologies and with our approaches for extended periods of time, not just for 7 days. Unfortunately, I don't have 1 or 2 year data at this point in time. I can show you some results from a smaller pilot study we did we did already 2 years ago or so, where we wanted to try, okay, let's see, can we do 4 weeks of ecological momentary assessment? So we developed our own app at the time. We developed it in such a way that it was possible to pair it with a Fitbit wearable, and we distributed this to 40 participants. And we asked them to wear the device, to participate in the study, or I don't even remember exactly, I think 10 weeks or 12 weeks or so. For the first 4 weeks of the study, we planned ecological momentary assessments on top of wearing the wearable device. So over 4 weeks, we sent about 160 questions to participants at various times of day on various topics to try to see how well they would respond. The circles represent the number of participants who wore their wearable device, and these crosses indicate the number of participants who actually replied to the surveys. We had multiple surveys coming in a day, so it's a bit of an interesting way to present it. But what we saw is that about 50% of our surveys across these 4 weeks were actually answered by the participants, and we couldn't really tell that participation dropped very substantially. It was about the same throughout the entire 4-week observation period. What I found, so that by the end of 4 weeks, still close to 90% of the participants were wearing the wearable device and were answering the surveys. Then we stopped the surveys, and this is what happened immediately. Pretty much within only 4 weeks, the willingness to wear the wearable device dropped from about 90% to 30%, despite us telling them beforehand, and also even at the point of recontact, that the study is not over, and that actually we wanted them to wear the device for the entire period of the study. So this was a very preliminary small-scale studies. I think what we have seen in the literature by now, from larger studies, one for instance also here from Singapore, is that if you give wearables to individuals, the novelty factor wears off very quickly. And you need very strong engagement strategies to actually keep participants engaged in a study and keep participants engaged in answering surveys, but also in using the different devices that are necessary for this type of study in the first place. We are currently using data from the National STEP Challenge in Singapore, which has also a wearable device and a smartphone application, and hopefully it will give us some more generalizable information of device wear over the entire duration of the national of a long-term intervention or health promotion strategy at a national level. So, coming to a brief summary of my talk. Obviously, there's a lot of potential in terms of lifestyle, changing lifestyle behaviors. Lifestyle is key to population health, and if we want to prolong life and prevent disease, we need to be able to promote healthy lifestyles in the population. Not just physical activity, obviously, but also other lifestyle behaviors. There's a lot of opportunities, or at least we see a lot of opportunities in the use of mHealth strategies. Firstly, in the context of ecological momentary assessment, to actually improve our understanding why individuals engage in a certain behavior. And this would enable us not just to develop technology-based interventions, but also to develop more broader socio-ecological interventions. For instance, changes to the built environment, changes to policies and so on, if we detect or identify them as relevant to individual behaviors. But beyond that, we also see that there's a considerable potential of using mHealth for developing personalized lifestyle interventions, and thereby improving the effectiveness of existing strategies that have traditionally been used for a long period of time. I tried with the examples I've shared with you to highlight a few of the challenges that we have identified in our research, and I'm sure others have identified similar challenges, but perhaps also some other challenges. An important one for us, coming from a population health perspective, is how generalizability. Will the data that we are generating be generalizable to the population? What does it tell us for the entire population, really? We've noticed quite substantial device-related issues about the incompatibility of devices on the one hand, but also in relation to the accuracy of devices. And this is despite the always cited major technological developments and advances over recent years, I think it is still something one needs to be mindful of when trying to use these kind of technologies in the future. And then in the context of implementing them in interventions, if you really believe that they can change, that these kind of personalized lifestyle intervention can change health outcomes, hard clinical health outcomes, we probably need to do a lot more research to actually find ways to strengthen participant engagement and keep them in our interventions to really, get them to the point that they can actually realize the health benefits that are necessary. Because hard clinical endpoints can obviously not be improved within just 6 weeks or 4 weeks or so. So in that sense, a lot of opportunities, some challenges. So I think when I think about personalized lifestyle interventions using mHealth, it's definitely something we want to pursue in the future, but I think we also have to be realistic about the effectiveness that we can expect from these interventions in terms of the broader population, from the broader population health. And you've seen we are capturing a lot of data, we are collecting a lot of data, and at this point in time, often we don't even know what we can do with all this data. So if any of you feels the challenges that I've highlighted are actually a piece of cake for you, please don't hesitate to contact us. This is our research program, Panda. Visit our blog or send me an email personally. We will be more than happy to discuss and see whether there may be some potential for collaboration. Thanks a lot.
I'm curious that the step counts like focus much lower than those on the Is it something that you expected or?
No, it's not. Yeah, I mean, it's not something I expected, to be honest. My hypothesis was that this phone-based step data would be a lot lower than the wearable data because of the because of the way we treat our phones, right? We let them. My phone is in my backpack, for instance. Now, my watch has documented all this information. So I think you're exactly on the right track. I was somewhat surprised as well. We haven't dug into the data in more detail. We do see that the phone-based data is still about 10% or so lower than the pedometer data that we have, the pedometer step count data we have used. There's also a number of other studies out there that have looked into validating phone-based step count data that have always suggested that it's lower than data from the reference instruments that are usually pedometers or accelerometers.
So one thing we're trying to do is how can we develop, so take a Jedi for enhancing engagement and data collection. So you could imagine different treatments like those that are like reinforcements or like, here's an example of adolescents and young adults. You give them a little gift, you know how they send little meetings and stuff together all the time. So the service sends them a meme from a popular rock star in the middle of the day. Will they be more likely to reciprocate by answering your questions?
Yeah.
Or if they answer your questions in the day when you ask, are there particular reinforcers that they would find most attractive and would lead them to be more likely to answer questions tomorrow?
Yeah.
So you could imagine a whole personalized data collection strategy.
Yeah.
Where the goal is to provide the right kind of reinforcers, the right kind of enticements, so that people continue to stay engaged in that, so that they answer questions.
Yeah.
You thought about that? So it's like a Jedi.
Yeah. Yeah, I mean, we are beginning to think about it. I mean, these are excellent suggestions, and I think this is exactly what we need to do to really improve the quality of the data that we are collecting. We are currently in the process of implementing a larger cohort, technology-enabled cohort, together with Health Promotion Board here within NUS students, where we are planning to recruit about 1,000 or so, which will, one of the objectives will be to look exactly also at such aspects. How can we actually get people to be more engaged in our data collection through financial incentives, reinforcements, positive feedback, and other strategies. So that's definitely something that we are also thinking about, and I think it's a great suggestions. Yeah. Mm-hmm. 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 Yeah. 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 Thank you very much. Yeah. Actually, we have looked at Blender. We have used Blender Altman plots as well, but I didn't share any results here right now. But thank you. Yeah. 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 So, so the geospatial data has is an independent part in itself, where essentially we use spatial data, and we are colleague of mine, like I said, who's going to be on Friday, is trying to compile all this data or all the possible data for Singapore, where we try to map out the built environment. So essentially things like park access close to your location where you live, for instance, or the availability of sidewalks in your neighborhood and things like that. And we want to, and one of the objectives is then to relate this information within our cohorts of 50,000 participants to certain health behaviors or health outcomes. So in that sense, it's a very isolated question, or isolated question that we are planning to look into. On the other hand, we are trying to then combine this information, the geospatial data, with the location tracking information that we are collecting to understand, for instance, how much time does a person actually spend in a park in a day, or in a week, for instance. And when this person is in the park, is the person active or is she not so active? So this is kind of how we try to bring these two data sources together, the three data sources essentially. Yeah. We are currently in the process. Some steps are already taken. Other steps still have to come. There was a question up there, right?
What are you two thinking about what we're trying to figure out, like which kinds of interventions would be most effective for people? So to be very concrete, like you go about your science interventions, often that's kind of done by like teaching about the knowledge and so on, but just to be very concrete, things like which messages to be people, like, you know, who should we be saying what's your plan today? Who should we be saying to them? And think about like your few aspects. So kind of thinking about what messages we test out. To be able to collect it, what about messages and bring it across to people. Not just the time to message, kind of putting it on the video. You know, there's like 20-second videos that talk about goal setting,
Yes.
talk about motivations, impairments, external.
So, sorry, I don't quite get, I mean, I think you're perfectly right, but I don't quite get the question. What would you like to hear? Yeah. Yeah, so I think it fits in where, in terms of the timeline, we haven't done it yet. So, but this is going to be hopefully the next step for us. Essentially, that we will find a robust technological platform that will actually, first of all, we need the technological platform that actually allows us to do such things, and then we are hoping that we will be able to set up smaller studies where we can test exactly such things, where we can actually conduct certain micro-randomized control trials, where we can try to figure out what kind of message format is the most appropriate one, what kind of message content is the most appropriate one, what kind of timing is the most appropriate one, to then take it to the next level at some point and hopefully develop a more health-oriented outcome measures. And I know that some of the earlier ones, the micro-RCTs, are obviously already going on, and there are some interesting publications out there, and I hope that we will be able to learn from them.
then we go to double guidelines.
Mm-hmm.
It's actually meant for logging group targets.
Yeah.
And what we did last year is we put them in a notification pattern. So the notification system in that app, you can actually do this with your friends.
Mm-hmm. Yeah.
So basically, we allow us to say, set people that POC, and then they actually take care of the app for launch.
Mm-hmm.
So the pull request is because it's expensive, it's 2 p.m. or 4 p.m.
Mm-hmm.
And then you can get data back from how you set it up. And the thing you might like this was that we set it up so that not just send messages or quotes, you can also actually ask questions.
Mm-hmm.
Like you can ask, which of these reasons didn't you exercise? Click that checkbox to say which of these describes why you didn't exercise speed.
Mm-hmm.
A, I was to try it. B, I found this important. C. So the idea is it's actually kind of a short, it's very good notification pattern of code with interventions. So ask specific questions. And the final part of it is like follows. So we actually ask people, is there a best message we should send you?
Mm-hmm.
Write a message you want to send you next week. So when we're looking to deploy that big challenge for us is basically looking at the class and all this kind of drama. So if you're interested in those kind of things, that would be nice.
Yeah, I think this sounds fantastic. I mean, we have also developed our own app, but it has its limitations. And what we came to realize, there's not going to be the one technology that allows us to do everything. So probably this may be a fantastic platform to do certain things, and there may be other platforms for other things potentially. Thank you. Yeah, so the definition there is very straightforward, not meeting 150 minutes of moderate to vigorous physical activity per week. Yeah, if you compare the questionnaire data, so that's one of the reasons. So the questionnaire we have used here is very comparable internationally. So the regions, Southeast Asia, actually have, relatively speaking, fairly high physical activity levels compared to most other regions in the world. But Singapore is the sad outlier in the region. So in a sense, Singapore is more on the same level as most Western countries are in terms of physical activity levels. Yeah. So it's not dramatically worse than other Western countries, but it's also not better than other Western countries. Any other questions? If that's not the case, then yeah, thank you very much, and also for the discussion.